Okay, thank you very much. So there was actually a cancellation of the first talk, so I needed to take 2 talks in this session. I apologize for that. But I think this is a very important indication for DCB myocardial infarction. So I start with a quite old patient case. This is a very young patient with type 1 diabetes and severe hemophilia, or moderately severe hemophilia, had some spontaneous bleeding events and presented with unstable angina. And there is a very tight LAD lesion, some moderate disease in the proximal part. What we did here was we used a cutting balloon dilatation 1:1, followed by sequent please DCB. We only used aspirin in this case because the hematologist said that you shouldn't load this patient with P2Y12 inhibitors. So we didn't use that at all. There is non-flow limiting dissection. We followed this patient 10 minutes on table. There were no ECG changes. Followed the patient overnight and then discharged. Had only 100 milligrams of aspirin for 4 weeks and then only 50 milligrams. The patient had another angio 10 years later, and you can see that there's good healing of the DCB treated area and no ischemic or bleeding events related to the PCI. So what is the evidence for NSTEMI? I think the first paper published or randomized trial was the PEPCAT and NSTEMI trial, which compared paclitaxel DCB against stent. Well, the issue with this trial is that half of the patients received bare metal stent, and they then had to change the protocol because of the guidelines, so that the other half of the patients received current generation DS. So that's the problem in this trial. But I could show that DCB, first of all, was safe. There were no acute occlusions. There was one stent thrombosis, and there was no difference between actually, the DCB was actually better in comparison to the overall stent group. Then in the basket small 2 trial, there was a subgroup analysis of NSTEMI and unstable patients. There were a few STEMI patients also. And on the right side, you can see the ACS cohort consisting of about 200 patients. And there was a trend towards better outcomes with DCB, but it was not powered for statistical significance, but still showed that DCB is safe in NSTEMI and small vessels. About solution de novo trial, we don't have any subgroup analysis, obviously, because the main paper has been only submitted recently, but there will be a substantial subgroup of acute coronary syndromes, excluding STEMI in this trial. So how about STEMI? Do we have any evidence? We have one randomized trial with no clinical endpoints. It used FFR at 9 months as a endpoint, compared DCB against DS after successful primary PCI, and there was no difference between FFR between these groups. And when they look at the clinical endpoints, I think there was no, very difficult to see that, but I think there was no statistical significantly different in this very small number of patients. So this is the first randomized trial on this topic. And then there is one big observational study from Norwich, from the Simon Ecclestole's group, published a couple of years ago in JAK interventions. They actually had quite a lot of primary PCI patients, 1,200 overall. All had de novo disease, and they used either DCB or second generation DS. and had, I think, quite similar patient populations, mean age 66 years in both groups. Only there were two, aspects showing heterogeneity. There was a difference between the stroke and smoking status between the groups. There are a couple of interesting observations. More DCB was used in bifurcation lesions as compared to drug-eluting stents, including true bifurcations, and then more large vessels over 3 millimeters were treated by a drug-eluting stent. If you look at the dissections, angiographic dissections, majority of lesions did not have angiographic dissection after DCB. Some had type A or B dissections. There was no difference between the TIMI flow between the groups after angioplasty. If you look at the overall result, which is on the left, in the unadjusted analysis, there is no statistical significance in all-cause mortality between the groups. And when you do adjustment for certain risk factors, it's even more equal between the groups. So I think this observational study is sufficient to show that treatment of STEMI doing primary PCI with DCB is very likely safe, but we need a randomized trial on this topic. What is, I think, interesting in this trial was also that less aspirin was used after DCB driven or DCB primary angioplasty in comparison to stenting. So I think this has implications for bleeding risk patients. This is one case from our cath lab. It's 69 years old male with anterior STEMI. There was already some flow in the culprit vessel. Importantly, it's a bifurcation lesion. Probable also that there is some thrombus in the culprit. We did a small ballooning, and then this is after small balloon, and at this point it's very important to give some nitro and have a real vasodilatation, and especially if you aim at DCB, to have any estimate of the true vessel size. Then we treated this with NC balloon 1:1 ratio, and this is after the predilatation. The flow is quite good. There's some pinching of the diagonal branch, no severe dissection. So I think this is, in our practice, good to go with DCB. And this is after similar size paclitaxel DCB, and also the side branch looks better when the wire has been pulled out a bit. And this is from the other angle. It's very important to check, of course, a second angle, and preferably without the wire, the situation. So I think it's almost a stent-like result. And which was, I think, important, this patient received a dual antiplatelet therapy, but because we didn't have the labs before PCI, we didn't know that the patient was anemic, and actually he presented with a persistent hematuria, and we could stop aspirin immediately, and in case of severe bleedings, you can also stop ticagrelor in these cases, at least for a while. So, as mentioned, we don't have any clinically powered trial in primary PCI and DCB, but there is one ongoing in Spain. It's called Copernican trial. It's powered for clinical endpoints, 1,200 patients. And the patients will be randomized after successful guide wire crossing, so before predilatation, 1:1 to DCB-oriented group and DS group. So in DCB arm, you are allowed to use also stents. The primary endpoint is target vessel myocardial infarction or ischemic TLR at 1 year I think this will be a very important trial. How about thrombus? This is a very, I think, important question, especially in primary PCI. What should we do with thrombus? So this is a very young patient presenting with anterior myocardial infarction, and what he had, sorry about this, had, can you please start it over? What he had was a huge thrombus in the proximal LAD. We had to do thrombus aspiration, and then we staged the procedure until 2 days so that there will be better chance for the drug to penetrate the vessel wall, and actually had the patient come back at 6 months, and the result was very, very nice. So this is the case. So thrombus burden in OCT, we did some dilatations, but more work at 2 days, several paclitaxel DCBs, and this is the 6 months angio showing very nice healing. So I think this approach is very good in young patients. So I would like to conclude that randomized trials have shown there's one randomized trial for NSTEMI, and the others have shown quite substantial subgroup of NSTEMI patients. We are waiting for the results of the solution de novo trial on that aspect. It seems to be safe in small RCTs and observational studies, especially the primary PCI. I think the sweet spot of DCB in ACS populations are the young patients and then the elderly high bleeding risk patients. And then I think the excess thrombus must be removed from the vessel before DCB. It means quite aggressive aspiration techniques, even with a guideline facilitated aspiration, and then staged PCI. Thank you for your attention.